Abandon all hope, ye who enter here. What that means. That is the last line on the inscription to the gates of hell in Dante's Inferno. Dante described 9 concentric circles in hell, each one for a specific sin that the person committed. You can see here's the circle for the lustful, the gluttonous, the greedy, all the way down to people who commit violence against one another. And down at the very bottom is the 9th circle of hell for the treacherous people, and in that circle resides Satan. Well, what about people who are not only treacherous, but lustful and greedy and heretics and things like that? I have discovered yet a 10th circle of hell. All of the 9 circles that Dante described have horrible, horrible punishments associated with them. But those punishments pale in comparison to what goes on in the 10th circle of hell. There, for all eternity, people who end up there are forced to listen to an endless series of lectures on the lymphatic system. And it is because I wish to encourage moral and upright behavior among you that I'm going to give you a little taste of what that 10th circle is like today.
All right, what is the lymphatic system? Capillaries have a pressure, a hydrostatic pressure within them. It's part of the blood pressure. It's lower than in arteries, but higher than in veins. And the pressure, the hydrostatic pressure within the capillary systems, capillaries of your body, tends to drive water out of the capillaries. Your blood is mainly water. Tends to drive water out of the capillaries into the spaces between the cells, the intercellular spaces of your tissues. On the other hand, blood has a lot of protein in it, largely albumin, and that creates what's called a colloid osmotic pressure, or an oncotic pressure, which tends to suck water into the capillaries, because the protein concentration is higher in blood than in the intercellular spaces of the tissues. At any moment, the hydrostatic pressure in the capillary can dominate and fluid can go out into the intercellular space. Or, some later moment in time, the oncotic pressure may dominate and water may be drawn into the capillaries. And it varies from tissue to tissue, up and down, minute by minute. Because the hydrostatic pressure of the capillary depends upon whether the arteries are open or the veins are partly contracted or not. You don't care about that stuff. I don't care about that stuff. The net effect, however, over the course of a day, all right, the net effect is for fluid, over the course of an hour, is for fluid to leak out of your capillaries. Over any measurable period of time, fluid tends to leak out of your capillaries into the spaces between the cells of your tissues. Also, and very importantly, protein, albumin primarily, tends to leak out of capillaries also into the spaces between the cells of your tissue. Now,
protein can leak out of capillaries, but it can't get back in again. So you've got a situation where protein is constantly leaking out of your vascular system, and fluid is leaking out of your vascular system, and something's got to return those two things back to it. And that's what the lymphatic system does. In between the cells of your tissues are these tiny blind capillaries called lymphatic capillaries. Their walls are made up of a cell type that allows things more easily to pass between the cells and get into these lymphatic capillaries. So water can easily go into them. Of course, water can easily go in and out of capillaries too, but protein can get into these lymphatic capillaries in a way it cannot get into blood capillaries. So these lymphatic capillaries are tiny little things which join together to form bigger things called lymphatic vessels. And the lymphatic vessels join together to form even bigger things called lymphatic trunks, one of which you have seen, the thoracic duct. And these lymphatic trunks empty into the venous portion of your bloodstream here in your neck. I'll give you the details of it later. So in that way, this fluid and protein that leaks out of your blood capillaries is returned to the venous system and back into the circulatory system. At certain places along the path of lymphatic vessels are these accumulation of cells called lymphocytes surrounded by connective tissue. These accumulation of cells surrounded by connective tissue are called lymph nodes. And so the lymph percolates through these lymph nodes before it gets returned to the blood system. And these lymph nodes have as their job removing from the lymph bad things that get into it. Because as I said, lymphatic capillaries are highly permeable and things can easily get into them. They need to be in order to return that protein. But unfortunately, some of the things that can get into them are bacteria or viruses or cancer cells. And it's the job of the lymph node to trap and kill the bacteria or viruses or cancer cells that get into the lymphatic system, and in that way help you to stay healthy. And therefore, even though in dissection we can barely dissect any part of it, the lymphatic system, we see the thoracic duct, we'll see a few lymph nodes where you saw some when we were dissecting the chest, and maybe some of you saw some down in the groin region when you were skinning the abdomen, but we don't see most of it. I read somewhere there are 800 lymph nodes in the body. Well, if we see, 10, that would be a lot. But it's so important because bacterial infection can take up residence, can overwhelm the lymphocytes and take up residence in a lymph node, and then you get a painful lymph node, and you have to look at where that node is draining from to figure out where the original source of the infection is. And probably nowadays antibiotics take care of a lot of that. So nowadays the most important reason to know lymph node distribution is that cancer cells take up residence in lymph nodes. Now they produce a hardening and swelling of the lymph node that is not painful. It's a painless swelling. But always physicians, surgeons are looking for people who have cancer, looking for spread to lymph nodes because it makes it much more difficult to deal with when the cancer is spread there. Or sometimes you find the spread of the node before you even know where the cancer is. And then you need to know the drainage pattern of that node so you can figure out where the primary site of the cancer is. Now, most of the lymph nodes of the body are located in relationship to major vessels. Sometimes arteries, sometimes veins, but if it's really small, it doesn't make any difference if you're located near the artery or the vein. They're both so close together, they're just located next to that group of vessels. But if it's a big vessel, it does, in fact, make a difference. Now I'm just reviewing for you what many things you will know, which are the names of some of the vessels I will have to refer to when I talk about lymph node distribution. So we know that the common carotid arteries extend, one from the aortic arch, one from the brachiocephalic into the neck. We know that the subclavian arteries extend into the upper limb. The axillary artery is the name given to the subclavian beyond the lateral border of the first rib. Celiac artery, you dissected it. You will dissect the superior mesenteric artery, branch to the midgut, and you will dissect today the inferior mesenteric artery. They branch off the front of the aorta to the hindgut. You will not dissect for a little while the terminal branches of the aorta, which are called the common iliac arteries. And those two terminal branches of the aorta, those two common iliac arteries, give off each one gives off an internal iliac artery to pelvic structures and continues on as an external iliac artery that will go and feed the lower limb. And that external iliac artery, as Dr. Larson mentioned to you, passes behind this black thing, which is the inguinal ligament, and then changes its name to the common femoral artery. And the common femoral artery gives off one branch. Well, I guess I'm not going to label it now. So let me go back up to some other branches. One you do know, a branch of the early branch of the subclavian artery is the internal thoracic, but clinicians, particularly surgeons, usually call it the internal mammary artery. They just use that term. They will not change the internal thoracic. And so pretty much, we will accept either one on any exam answer, and almost in a way encourage you to use internal mammary because that's what they will use. A branch which also you were supposed to, we did see that, by the way, the internal mammary artery. The lateral thoracic was the branch you were asked to see. It's a branch of the axillary artery, and it runs along the side of the chest cage. This is an artery you will not dissect until we do the upper limb. It's called the subscapular artery. It's also a branch of the axillary artery, but further along that course, and it does the part of the shoulder girdle. These you've seen, posterior intercostal arteries, which are given off from the thoracic aorta. You will see a little bit later in our abdominal dissection, lumbar arteries, which are the abdomen's version of a posterior intercostal artery, given off from the abdominal portion of the descending aorta. Now, I don't know, I didn't label these in the previous slide, maybe because it was getting crowded here. The common femoral artery, right after it emerges from behind the inguinal ligament, gives off a couple of cutaneous branches, which you were asked to know about. Anyway, maybe you saw it in a section called the superficial epigastric, which runs in the subcutaneous tissue towards the belly button. One which we never ever find is called the superficial circumflex iliac, which runs in the subcutaneous tissue towards the crest of the ilium. So that may be all of the arteries that I will have any occasion to refer to today. Here are, I can't believe I'm not blocking you. Here are some of the veins I will have occasion to refer to today. The internal jugular vein, you certainly heard the name because you know it forms the brachiocephalic. It runs lateral to the carotid artery in the neck. The brachiocephalic veins you know about. The common femoral vein is a vein which drains the lower limb and lies medial to the common femoral artery behind the inguinal ligament. The common femoral vein receives a big cutaneous vein called the great saphenous. And the great saphenous vein receives veins which accompany the superficial epigastric and superficial circumflex iliac veins. And those are simply called superficial epigastric vein and they accompany the arteries, and those are called superficial epigastric vein and superficial circumflex iliac arteries. They drain into the great saphenous, which drains into the common femoral, and I haven't labeled anything after that. Common femoral becomes external iliac, and then there are internal iliac and common iliac veins as well. There's a major group of lymph nodes draining the head and neck, lie surrounding the internal jugular vein, and those are called deep cervical lymph nodes. The major group of nodes draining the upper arm, but more than just the upper arm, but certainly an important thing that they drain is the upper arm, lies in the vicinity of the axillary vein and these vessels which drop down from it, there should be a vein alongside here too, obviously, the lateral thoracic vessels and the subscapular vessels. And those are called the axillary lymph nodes. Along the axillary vein, lateral thoracic and subscapular vessels. Anatomists divide all of those axillary nodes into 5 named groups. The group that is along the lateral thoracic vessels can be called lateral thoracic nodes, but tends not to be. I call it those pectoral nodes, but anterior axillary is probably their proper term. But I'm not going to, well, this is the only group, this is the only name that's crucially important to me, that you know that there is a group along these vessels. There is a group along the subscapular vessels called subscapular nodes or posterior axillary nodes. There is a group along the part of the axillary vein which is distal to where the subscapular vessels arrive, and those are called lateral axillary nodes. Then there's a group that receives the lymph from the subscapular and from the pectoral and from the lateral group, and those are called the central nodes. So those 3 other groups send their lymphatic vessels to converge on the central nodes, and then the central nodes drain to a group which is proximal to where the lateral thoracic artery comes in, and those are called the apical axillary nodes. Now, this is a nomenclature which is not used by clinicians. So I give it to you. People say, what about, I have no idea what step 1 does. I don't know if I would ever get into this detail. Of all that you may come across in your readings, these names of these groups, the ones that are important here to me, the one that's important that you know is the anterior axillary or pectoral group of nodes. There are also nodes along the internal thoracic vasculature. Those are variously called internal thoracic nodes, internal mammary nodes, or parasternal nodes. I think the clinicians usually call them internal mammary nodes. I usually call them parasternal nodes. Nobody calls them internal thoracic nodes, other than people who write anatomy books. There are some lymph nodes around the ascending aorta in front of it, in front of the origins of the great arteries that come from the ascending aorta, and around the left brachiocephalic vein. And these are called anterior mediastinal nodes. Even though they lie in the superior mediastinum, they lie in the anterior part of the superior mediastinum, so they're called anterior mediastinal nodes. There are nodes all alongside the aorta, just where the intercostal arteries arise, and these are called posterior mediastinal nodes. There are also nodes all along the aorta in the abdomen. Those are called para-aortic nodes, or sometimes lumbar nodes, and there's referred to a left lumbar chain and a right lumbar chain of nodes on either side of the aorta. But because the inferior vena cava sits here to the right of the aorta, the right lumbar chain of nodes is often called the paracaval chain, because it's around the inferior vena cava, in the vicinity of it. The common iliac nodes are around the common iliac artery and vein. The internal iliac nodes are around the internal iliac artery and vein. The external iliac nodes are around the external, actually around more, becoming more around the vein, the external iliac vein. The nodes here around medial to the common femoral vein, which we should, if we want to make our lives easy, since we call these common iliac nodes and internal iliac nodes and external iliac nodes, wouldn't it be nice if we called those common femoral nodes? They're not called common femoral nodes. They're called deep inguinal nodes. They lie medial to the common femoral vein in the femoral canal region. And the nodes that are along the terminations of the superficial circumflex iliac and superficial superficial epigastric and superficial circumflex iliac vessels, veins, around their termination, and at the beginning, or not the beginning, at the end of the great saphenous vein. So it's around the termination of these veins into the great saphenous and around the great saphenous vein as well. Those are subcutaneous nodes. They're in the subcutaneous tissue. So far, all of these have been deep structures until we get to this one group here, which lies in the subcutaneous tissue and are called superficial inguinal nodes. And those are the ones you may have seen in dissection if you carry your skinning down that low. They tend to be the biggest in the body, and you actually can often feel them in healthy people. Otherwise, these things are really hard, almost impossible to feel in a healthy person. The pelvic nodes are particularly important because, for an obstetric gynecologic point of view, because this is where the pelvic organs drain, including the uterus and the ovary, which are susceptible to cancer. Ovaries have a double drainage, you'll hear about when we do pelvic anatomy. But the pelvic nodes, the gynecologists refer to pelvic nodes. And the pelvic nodes in gynecologist terminology is a combination of the external iliac nodes, the internal iliac nodes, and some nodes along some vessels here called the obturator vessels, which are branches and tributaries of the internal iliac artery and vein, and those are called obturator nodes. So those three groups, external iliac, internal iliac, and obturator, are called pelvic nodes by the gynecologic surgeons, and they communicate very widely with one another, and anything that gets into one can spread to the other. The nodes that lie along the vessels which arise, the arteries which arise from the arteries which arise to feed the gut tube, get their name by the vessel along which they lie. So any nodes here along the splenic artery would be called splenic nodes, and here they'd be called gastroepiploic nodes. And here along the left gastric artery, they'd be called left gastric nodes, and I'm not going to name every nodal group. As you're coming across an artery that feeds the gut, remember that there are, in fact, lymph nodes alongside those arteries. You don't see them. They're too small for us to see in dissection, really, mostly. And they run all the way out all the way out to the margins of the bowel. Here, this is a picture of the lymph nodes all of the colon, but they're really all along every branch and every arterial branch that goes to any region of the bowel. And the ones that lie for the small intestine are often called mesenteric nodes, because we know that the mesentery is carrying all the vessels out to the small intestine. But here would be right colic nodes, ileocholic nodes, things like that. All of those nodes from the bowel drain centrally towards the nodes which sit right at the origins of the celiac artery. I guess you could call those celiac nodes. I guess you would. Nodes which sit on the front of the aorta at the origin of the superior mesenteric artery, which we will call superior mesenteric nodes, and nodes which sit on the aorta at the origin of the inferior mesenteric artery, which we will call inferior mesenteric nodes. But together, the celiac nodes, the superior mesenteric nodes, and the inferior mesenteric nodes sitting on the front of the aorta are called preaortic nodes. So those are the most central members of all of the nodes that run out along vessels to the bowel. I said nodes tend to lie among big vessels, arteries sometimes, veins sometimes. Doesn't make any difference if they're small. There's one group of nodes that does not lie along big vessels, and those are the nodes that drain the lung. They have their relationship to the tracheobronchial tube system, not to the vasculature. There's a bunch of nodes along all of the tracheobronchial tubes. Anatomists, again, have a nomenclature which in this particular case makes eminent sense, but I'm not going to ask you to learn it, but I'm going to give it to you anyway. Why? Because I'm mean. All right. But it makes more sense than the clinicians to me anyway. Any node that is along a bronchus that's surrounded by lung tissue, anatomists call pulmonary nodes. Any node that is at the junction of the main stem bronchus, or right where the main stem bronchus enters the lung, so right just before the main stem bronchus enters the lung is called a bronchopulmonary node, so it's sort of the junction between bronchus and lung. Any node that's around the rest of the main stem bronchus is called a bronchial node. Nodes where at the junction of the trachea and the bronchi are called tracheobronchial nodes, and nodes that are along the trachea are called tracheal nodes. So this makes perfect sense. This is what the clinicians use. You do not have to know this. This is from the International Association for the Study of Lung Cancer Lymph Node Map. People have worked very, very hard to give as many names as they could to the different nodes here so that they can stage cancers, and it makes a big difference to them. Is it in the 4L group? Is it in the 2L group? And that tells them a lot about it. There's no way that I can't remember all these nodal groups either. But there are a few I think you should know because these are very common terms used by clinicians even who are not lung cancer specialists. Any node such as this dark blue or light blue or dark red or orange, which lies along the trachea, is simply called paratracheal. So the nodes that lie along the trachea are called paratracheal, even though you know from the previous slide that they're divided themselves into 4 groups. Some clinicians use the term if a paratracheal node sits on the front of the trachea, some clinicians will call it a pretracheal node. But it's just part of the same group, and they all communicate with one another. All right? But you'll hear the term pretracheal, and what it just means is a paratracheal node that sits on the front of the trachea. Any node which lies along a main stem bronchus is called a hilar node. All right? That's not bad. That's for the hilum of the lung. The nodes which lie in the acute part, or in the inferior to the bifurcation of the trachea, are referred to as subcarinal nodes, and that makes sense because that's inferior to the carina. And all of the nodes that are around secondary, tertiary, and quaternary bronchi have different names by the cancer specialists, but we will just refer to them, and many clinicians who are not cancer specialists refer to them as parabronchial nodes. So this is the terminology I tend to use. If it's around any secondary bronchus or beyond, it's a parabronchial node. If it's around a primary bronchus, it's a hilar node. If it's in the angle between the two main stem bronchi, it's a subcarinal node. And if it's along the trachea, it's a paratracheal node. Now, those are all the nodal groups whose names I know, all right? I know one or two more, but I won't get into nodes. How do these nodal groups, how does lymph get to them? And what routes does lymph take to get back to the blood system? Generally speaking, the lymphatic drainage of any part of the body, any deep structure, so any deep structure of the body, the lymphatic vessels will run backwards alongside the arterial supply until it reaches one of these named group of nodes. That's it. Just runs, you know, it's like visceral sensation running backwards along the sympathetics, but this is lymphatic vessels flowing backwards alongside the arteries which feed that region of the body until you come across one of these groups of nodes. And that's it. That's all you have to think about. So that's how they get to a nodal group. The lungs are an exception to that, just as, because the lung nodes don't lie along vasculature, so the lungs drain in a different way. The lower lobe, obviously the parabronchials drain up to the hilar, and the lower lobe usually has some that go to the subcarinal nodes, and then the hilar and the subcarinal go up to the paratracheal on that side of the body. And the upper lobe does drain to hilar and paratracheal, but upper lobes tend not to go to subcarinals. And that's the right side, and then the left side is similar. Lower lobe goes to all the parabronchial nodes, drain to hilar nodes, and some of the lower lobe lymphatic vessels go to subcarinal, and others go straight to paratracheal, but the subcarinals themselves drain to paratracheal. This numbering here reflects the likelihood that any cancer in a portion of the lung will cross to the other side. By and large, a lung drains to its ipsilateral paratracheal nodes. So the right lung, by and large, will drain to the ipsilateral right paratracheal nodes, and the left will drain to the ipsilateral left paratracheal nodes. But the inferior lobes, because they also drain to the subcarinals, and the subcarinals can go to either left or right, the inferior lobes of the lungs have a higher incidence of bilateral drainage than do the superior lobes. The highest incidence of bilateral drainage is from the left lower lobe. The second highest incidence of bilateral drainage is from the right lower lobe. The third incidence of bilateral drainage is from the left upper, and the fourth from the right upper. So, to try and make this easier to understand, the left lung has generally a higher incidence of bilateral drainage than the right lung. No one knows why. No one knows why. And the lower lobes have a higher incidence of bilateral drainage than the upper lobes. This is very important for people who come into your office with a lower left lobe cancer, because you have to be highly suspicious of bilateral drainage. You have to actually make an attempt with PET scans or bronchoscopy to determine if it's bilateral, because that's generally considered inoperable. If you have tumor in both left and right paratracheal chains, it's considered inoperable. If, in fact, your tumor is confined to one side, then you can take out the lung or the lobe, as the case may be, and the chances of survival are much better. How do the various nodal groups themselves drain? Now, we've traced lymphatic vessels backwards along arterial supply to some named nodal group. How do those different nodal groups drain? The axillary nodes, here I show the pectoral group draining to the central nodes, and the subscapular drain to the central, and the lateral drain to the central, and the central is drained to the apical. I said I wouldn't use those terms, but I am. But from the most medial of the axillary nodes, from the most medial of that apical group, comes a big lymphatic vessel, which you could dissect, called the subclavian trunk. the jugular deep cervical nodes from the most inferior of the deep cervical nodes. The higher ones drain to the lower ones. From the most inferior deep cervical nodes comes a lymphatic vessel, which you could dissect, called the jugular trunk. The paratracheal and pretracheal and anterior mediastinal nodes drain through small vessels, hard to dissect, and the peristernal nodes, or internal mammary nodes, drains through a small vessel. But all of the vessels from the para and pretracheal nodes and the anterior mediastinal nodes and the internal thoracic nodes converge on another trunk called the bronchomediastinal trunk. So we've got all the axillaries going to the subclavian trunk, all the deep cervicals going to the jugular trunk, and internal mammary, lung, and anterior mediastinal nodes going to the bronchomediastinal trunk. These three trunks on the right side, this is the right side I'm talking about. It's true on the left side as well. But on the right side, there are these three trunks on both sides, both on the left and on the right. There are these three trunks. On the right side, the three trunks can enter the junction or the formation of the right brachiocephalic vein independently, so three separate trunks, subclavian, jugular, bronchomediastinal, will enter the formation of the right brachiocephalic vein, or any two can join one another, or all three can join one another. And if all three join one another, you are said to have a right lymphatic duct on that side. Now, we never dissect these things. They can be dissected, but we never do. So I never know the incidence of right lymphatic ducts at all. I have no clue. Have no interest. I'll tell you what happens on the left side with those three trunks, bronchomediastinal, jugular, and subclavian, in a moment. Down here, superficial inguinal nodes, those subcutaneous nodes around the terminations of the superficial circumflex iliac vein, the superficial epigastric vein, and the great saphenous vein. Those superficial inguinal nodes drain to the deep inguinal nodes, which are medial to the common femoral vein. The deep inguinal nodes drain to external iliac nodes, which are around the external iliac vessels. The external iliac nodes drain to common iliac nodes, which are around the common iliac vessels. The internal nodes drain to common iliac nodes, and of course obturator nodes are draining both either to external iliac or internal iliac, so all of that lymph is ending up in the common iliac nodes. And so the entire lower limb and pelvis is ending up in common iliac nodes, for as far as we know right now anyway. The common iliac nodes drain to the ipsilateral para-aortic nodes. So the right common iliacs go to what we might call the paracaval nodes, and the left go to, and I haven't drawn this on the left, the little yellow arrows, I won't draw on the left, go to the left para-aortic chain of nodes. And the lower members of the para-aortic chain drain to the higher members of the para-aortic chain. So here's now a blow-up view of the right para-aortic chain of the paracaval nodes and a blow-up view of the left. And we know all that lymph is being gathered from the superficial inguinal to deep inguinal to external iliac and internal iliac to common iliac, ending up in these para-aortic chains. And the most superior of the right para-aortic chain gives off a big dissectable lymphatic trunk called the right lumbar trunk. And the most superior of the left lumbar chain of nodes gives off a dissectable vessel called the left lumbar trunk. Now all of the lymph, all of the lymph that is along the distribution of the inferior mesenteric artery is going to drain to the inferior mesenteric nodes, which are the most inferior part of the preaortic nodes. The inferior mesenteric nodes are going to drain up to the superior mesenteric nodes, which are getting the lymph from all over the part of the bowel fed by the superior mesenteric artery. And the superior mesenteric nodes are going to drain up to the celiac nodes, which are getting all of the lymph from the gut fed by the celiac artery. And one of these celiac nodes is going to give rise to a big dissectable lymphatic vessel called the intestinal trunk. So all of the lymph from your entire intestinal system, your gastrointestinal system in the abdomen, and pelvis is ending up in this intestinal trunk. By the way, as an aside, I told you lymph is fluid and protein and whatever noxious beings might have got into your lymph. There's one place where there's something else added to lymph, and that is in the bowel. Fat that you eat is absorbed into your lymph, not into your blood. So the lymph that returns from the small intestine is a fatty lymph. And that fatty lymph, it's whitish in color, actually. So it's really different in appearance from the lymph everywhere else because of the high content of fat in it. That fatty lymph is called chyle. So the intestinal trunk drains lymph from the entire abdominal pelvic GI system, the right lumbar trunk from the highest of the right lumbar chain, the left from the highest of the left lumbar chain. And those three trunks meet one another over the L1, L2 disc usually to form the thoracic duct. The thoracic duct is carrying all the lymph from your GI, abdominal pelvic GI system, and from everything really essentially below the diaphragm. There's a few exceptions I'm not even going to get into. Sometimes there's a dilatation here at the beginning of the thoracic duct, and when that, I don't think did I label it? Yes. If that dilatation occurs, that's called then a cisterna chyli, and that reflects the fact that people realize that chyle was entering the thoracic duct at that point. I've seen a couple of thoracic ducts form in my life, but I've never noticed a dilatation there. Well, we don't ask you to look for it, and I haven't seen many of them. And you know the thoracic duct then runs to the right of the aorta, and you followed it for a goodly part of its course. As it's doing that, it is getting lymph from all the posterior mediastinal nodes. So now it's starting to get lymph from above the diaphragm as well, because all these posterior mediastinal nodes are draining things served by any branch of the thoracic aorta. And then the thoracic duct comes, and you will see in dissection, and this we will look for, empties into the beginning of the left brachiocephalic vein at the root of the neck. And on that left side, the subclavian, jugular, and bronchomediastinal trunks may join the thoracic duct, or they may enter separately into the beginning of that brachiocephalic vein on the left side in any combination. That is the entire pattern of lymphatic drainage of the deep structures of the body. The deep structures, that's what I've been talking about so far. The pattern of lymphatic drainage of the skin and subcutaneous tissue is different. Maybe easier, really, in a way. There are two planes that we are interested in here, one across between the clavicles called the transclavicular plane, one across the belly button called the transumbilical plane. All skin and subcutaneous tissue above the transclavicular plane goes to deep cervical nodes, so eventually using the jugular trunk to get back. Skin and subcutaneous tissue between transclavicular and transumbilical ends up partially in the axillary nodes and to a smaller extent in the internal mammary nodes. So they're taking two different, those that end up in the internal mammary will end up in the bronchomediastinal trunk. Those which end up in the axillary, the lymphatic vessels from the skin and subcutaneous tissue ending up in the axillary, will end up in the subclavian trunk. It's just the stuff, pretty much just the stuff near the anterior midline, which goes to the internal mammary nodes. Most of your subcutaneous tissue and skin of the region between clavicles and belly button go to the axillary nodes. The part of the subcutaneous tissue and skin inferior to the transumbilical plane those lymphatics converge on the superficial inguinal nodes. That's for all the lower limb and everything below your belly button. All converge on superficial inguinal, so therefore go to deep inguinal, external iliac, common iliac, periaortic, thoracic duct stuff. Now, having said this and suggesting that you do memorize this is not how to memorize, really. We only named 3 groups of nodes: superficial inguinal, deep cervical, axillary, and internal mammary. You have to be known that the truth is that if you are in a piece of skin or subcutaneous tissue within 10 centimeters of that line, you can either go to the side you're supposed to go to, or you can drain to across it to the one below it, or you can go to both of them. So you cannot say absolutely, and that's true of stuff in the midline too. Any skin or subcutaneous structure within 10 centimeters of the midline, whether it's on the back or the front, can either go to the right side, to the left side, or to both. So you cannot be confident that it's, that these things are going to go exactly to where this chart tells you. Because if you're close enough to these horizontal lines or close enough to the midline, you can have bilateral spread of any disease. Now, clinically, the most important subcutaneous structure between the clavicles and the belly button is the breast. So we know that subcutaneous tissue structures between the clavicle and the belly button go to the axillary nodes and internal mammary nodes, and the breast is no exception to that. The breast drains to both the internal mammary nodes and to the axillary nodes. The axillary nodes that get most of the breast drainage first are these ones that I asked you to learn the name of, the anterior axillary or pectoral nodes. Those get most of the, but it's not necessary. Lymphatic drainage can, in fact, go to subscapular nodes first. That is true. And most of the lymph, 75% of the lymph from the breast, ends up somewhere in the axillary nodal system. 25% of the lymph from the breast ends up in the internal mammary system. If you have a breast cancer, therefore, the likelihood is very much greater that it will metastasize to an axillary node than to an internal mammary node. If, in fact, it has metastasized to an axillary node, the chances are about 25%, maybe a little more, that it will also be in an internal mammary node. On the other hand, the good news is, if it metastasizes to an axillary node, it does not. If the axillary nodes you look at have no tumor in them, the chances are only about 5% that they will be in the internal mammary. Internal mammary nodes are very hard to find. Look, you can't feel them. You can't really access them easily. So unlike axillary nodes, as you'll see in a moment, can be accessed easily. So tumor is looked for in axillary nodes. And relying on the information that if there are none in the axillary nodes, the chance is only 5% that there would be in the internal mammary nodes. The nomenclature used by clinicians is easier than that used by anatomists. The clinicians say, here is our pectoralis minor muscle. And I know that before that would be, proximal to that would be part 1 of the axillary vein. Behind pectoralis minor is what's called part 2 of the axillary vein. Lateral to pectoralis minor is what we call part 3 of the axillary vein. They call any node lateral to pectoralis minor a level 1 node. Any node lateral to pec minor they call a level 1 node. And they say that because these are the nodes most likely to get metastasis. Any node behind the pec minor is called a level 2 node. And that's because generally you will have tumor going to a level 1, and if it goes beyond that, it will then end up in a level 2. And any node medial to pec minor is called a level 1 node. Level 3 node. And that means that it's spread beyond level 1 into level 2 to level 3, and that's obviously very bad. Now, having said that, and that is a typical pattern of spread from level 1 to level 2 to level 3, it is possible to get level 2 without level 1 nodes. It's possible to get level 3 without level 2 or 1 nodes, though it's not so common, really. But these are the nomenclatures that they will use, so when you get into the clinics, you're only going to hear level 1, level 2, level 3, and it only refers to the relationship of a node either lateral, behind, or medial to pec minor. I'm going to deal with this, and I'm going to show you a video. Virchow node. I said to you, well, all the lymph of the head and neck goes to the deep cervical nodes. But there are lots of nodes in the head and neck, and each of these have lots of names. And we're not going to be so, we're going to talk in the core concepts, submandibular and submental nodes, but most of these nodal groups I'm never going to mention by name again. But there is a particular group of the sort of an extension of the deep cervical nodes, which lies right behind or above the clavicle. And those are called supraclavicular, or sometimes transverse cervical, but almost always they're called supraclavicular nodes. And they drain into the jugular trunk along with the other part of the deep cervical nodal group. Here I've sort of indicated them here. Remember I told you that the jugular trunk can join the thoracic duct, and often does before the thoracic duct empties into the vein on the left. If you have a tumor of any region served by the thoracic duct, which is a lot of the body, so let's say you have a tumor of the stomach, let's say you have a tumor of the uterus, that tumor will spread to nodal groups that drain either the stomach or the uterus, as the case may be, and end up in the thoracic duct, and come here and can reflux into the deep cervical chain if the jugular trunk is connected to the thoracic duct. And these supraclavicular nodes are easily palpable extensions of the deep cervical chain. So you can have a tumor ending up here in the neck just above the clavicle. Its real source is from the abdomen or pelvis. If that tumor cell has migrated up the thoracic duct, then refluxed into the jugular trunk. By and large, you don't expect there to be tumorous nodes here unless you have a head and neck tumor. But here's a case where you can have a tumorous node in the neck from a disease which started in the abdomen or pelvis. Such a node is called a Virchow's node. A Virchow's node is generally a left supraclavicular node without involvement in any of the rest of the deep cervical chain. So that indicates to you if you have a tumorous left supraclavicular node without any other cervical nodes involved, that it probably is originating somewhere in the abdomen or pelvis, and it's a sign that you have to look for this tumor elsewhere. Some people, you can, I'll leave it at that. I don't want to get any more detail than that. All right, so let me show you a video, because in the old days, the only way you could, it was very hard to determine whether a tumor spread to lymph nodes except by surgery and exposing the entire nodal group and seeing what's happened. And in particular, breast cancer, started out with breast cancer, but this is used in many other regions now. Rather than open up a woman's axilla and take out all of the nodes of the axillary group and try and, or many of them, and try and assess whether there's tumor there, it has been determined that if you go and find the very first node that gets drainage from the region of the breast, that one node, and you see if that has tumor in it, and if it doesn't, you don't have to look at all of the others. Now, the node, the very first node that gets drainage from a particular region that you are interested in is called a sentinel node. So if a person has a tumor in the upper medial quadrant of her breast, and you could figure out what the first node to receive lymph from the upper medial quadrant is, all you would have to do is look at that node. And if that node is clean, you don't have to look at the others. And if that node isn't clean, then you've got concerns, then you may have to look, and you will have to do what's called an axillary node dissection. So I'm going to show you how this sentinel node is done. Now this is become very common for tumors all over the body now. Try to find the sentinel node for that particular region, look at that node, is that clean or is that involved with tumor? So I'm going to show you a video of how you do a sentinel node dissection for the breast.
Our patient today, MW, is a 71-year-old female who presented with a palpable mass of her breast. The mass underwent needle aspiration, but that was non-diagnostic, and she subsequently had a lumpectomy done in another hospital. This revealed a 2-centimeter invasive ductal carcinoma, and all the margins were negative. She presents now for a sentinel node biopsy. We've discussed the possibilities of doing a full axillary dissection or a sentinel node biopsy only, and she feels comfortable with the idea of doing a sentinel node biopsy, and we have discussed with her the risk of false negative nodes of about 4%. Our plan today will be to proceed with a sentinel node biopsy with frozen section. If that is negative, we will stop, and if that does show cancer on frozen section, we'll proceed with a full axillary dissection. Earlier today, approximately 1.5 hours ago, she underwent a lymphoscintigraphy, which is shown here on the board. This is the injection site here, and our lymphatic channel is extending up towards the axilla, and it was marked by our radiologist in the axilla. We will also be injecting her with blue dye in the operating room using lymphozurin blue in order to do a dual labeling, which has been shown to be the most effective in finding a sentinel node. This is the lymphozurin blue. This is the vital blue dye that we use for the sentinel node biopsy and intraoperative lymph node detection. We use 1 vial of this per patient, approximately 5 cc's of contrast of the blue dye, approximately 5 cc's of blue dye, and we're going to be injecting that around the scar that is formed in the hematoma cavity of the biopsy site, as well as around the scar in the intradermal location. And this will help us to intraoperatively identify the sentinel node, and then we can confirm that by using our handheld gamma detecting probe. There are various techniques for injecting the dye. Some involve using it intraoperatively once the tumor has been removed, or into the biopsy cavity once a lumpectomy has been performed. The optimal technique is with an intact tumor, but in this case today the tumor has already been removed, and we're going to be injecting around the biopsy cavity, which is palpable. Here we see the right breast. The incision that had been previously done is in the upper outer quadrant at approximately the 10 o'clock position. And I've circled the palpable hematoma, which is underneath, which will be our guide to injection of our vital blue dye. We'll inject approximately 4 cc's around the biopsy cavity, and then we'll inject in the subdermal right around the scar. Here's our syringe with blue dye. We're using a 20 gauge needle, and I'm going right in alongside the hematoma, and I'm going to inject about 1 cc. Be careful to wear gloves. This tends to get messy. I'm now changing to a 27 gauge needle for an intradermal injection. And I'll be doing that right around the scar here. One must be careful, as this does tend to stain the skin, and you need to warn the patient that their breast may be a little bit blue when you're done. And that may last for several weeks. The patient is draped. Here you can see the blue discoloration near the biopsy cavity where we injected the blue dye and where they've injected the technetium beforehand. Here is our proposed incision below the hair-bearing area of the axilla. When we're doing a sentinel node biopsy, particularly when we're using the blue dye technique, it's very important to make your incision lower down in the axilla than you ordinarily might in order to pick up the lymphatic. Now, we define a sentinel node as a node that is either blue, where a blue lymphatic runs into it, or that's hot on our gamma probe, or that's both blue and hot, or that's palpable when we get into the axilla. Generally, we use a dual labeling technique for breast cancer, where we'll initially try and find the blue lymphatic, trace it to a blue lymph node, and then confirm that it's hot with our gamma probe. We'll also then generally probe around the axilla to see if there are any other hot zones. The probe that we're using today is the Star Navigator probe made by U.S. Surgical. It's in a sheath now, sterile for the field, and you can see the computer portion of it with a digital readout. This gives both an auditory and a numerical readout. When we put it on the area of the technetium injection preoperatively, we get quite high counts in the range of 500. If we move it to an area that's not been injected, and here we are over the sternum, we're getting counts in the range of 0 to 1. And when we probe in the axilla, we're not getting a lot of activity, but that's not uncommon. And we'll probe again once we have things opened up and better exposed. Put a little self-retaining retractor in to sort of help us and help everybody here see what we're trying to find. The pitfalls of sentinel node in breast cancer tend to be in people with very fat axillae, where it's much more difficult to find a sentinel node, and also in patients who've had a wide excision like this patient, where the false negative rate and the failure rate is much higher. But I think I'm beginning to see a lymphatic already. And here we see a blue lymphatic. I'm going to try and demonstrate it right at the tip of my clamp. Can you see that? Okay. So that's our first blue lymphatic. We're going to trace that towards the axilla. And as we can see, it's coming up. And there's a little bluish discoloration here. Open that. Can we see that bluish discoloration here?
Sure can.
Right there at the tip of my clamp. That's going to be where the sentinel node is going to be, right in there. We've fulfilled the criteria now of finding a blue node with a blue lymphatic going in. We're going to confirm that that's a sentinel node and see if it's picked up any radioisotope. So we can see that that node is quite hot compared to the background. The background to the skin was about 1 to 2, and our probe is reading it in the mid-20s. When I move just a little bit away from that, maybe not even a quarter of an inch or so, we're down to the 2 range. And again, over the sentinel node, now that we know that it's picked up the isotope with the probe, we'll be able to remove the node, count it ex vivo, and check to make sure that we've in fact removed the node that is hot. So this looks like both a hot and blue node, the best of all possible worlds when dealing with a sentinel node, both picked up on the dual labeling. So we're going to go ahead and dissect out this lymph node, and then we'll check for any others. As far as the number of sentinel nodes per patient, our average in our study of the first 200 patients is that we pick up about 1.8 sentinel nodes per patient. Most of the patients have 2, occasionally we'll have more, and some only have 1. And here we see the node coming into view. We're going to try and get around it and then clip off the lymphatic to prevent the blue dye from leaking around while we look for other sentinel nodes. Okay, clip that, please. Here we have a blue lymphatic coming into our blue sentinel node, which we're going to clip off. It's coming in by several different pathways. This lymph node was relatively posterior in the axilla, and they can be found in anywhere in level 1 through level 3. After I've removed the sentinel node, I like to dissect it out and count it. Often you'll take out more than 1 lymph node, and we mark these as sentinel nodes for our pathologist. So I'm dissecting out this lymph node, and you can see the bluish discoloration here. And I'm doing this so that our pathologist will have an idea of where to freeze. That I'm going to ask them to do a frozen section on this. So this is what we thought was a sentinel node, and we're going to go ahead and count it. And what do our numbers read? We're in the range of 30 to 40 over this. The other parts of this specimen are cold, really no counts. So we're going to send this up as axillary tissue for permanent, and we're going to send this up as our sentinel node for frozen section. And again, we can see the bluish discoloration in the node, and we can tell that it is a hot node. You can hear that as well. What we're going to do now is we're going to go back to the axilla and look for any other sentinel nodes and check for any residual radioactivity. In the meanwhile, we're going to send that up for a frozen section. If this is positive, we'll proceed with a full axillary dissection today. If it's negative on frozen, it'll then be sectioned multiple times, after which it'll be sent for cytokeratin immunohistochemistry. And we're going to check around to see if there are any other sentinel nodes, any other blue lymphatic pathways. And we're also going to check to see if sentinel node right axilla. We're also going to see if there's any residual radioactivity that we need to go after. I'm probing around the axilla. Our counts are ranging 1 to 0. And I'm probing deep in all directions in an attempt to determine if there's any other areas that we need to be concerned about. We turn towards the biopsy cavity, and of course we pick up much higher counts. This probe is both shielded and collimated, but it does not know where the radioactivity is coming from. You have to show it. So if you point it toward the biopsy cavity, you'll get high counts. That can be somewhat deceiving, particularly if the primary tumor is quite close to the axilla. And I'm getting no residual counts in that axilla at all. We also make it a practice of palpating the axilla, looking for hard, firm, or palpable nodes. If any node is palpable, that'll be removed as well, and that also is a sentinel node and counted in the same way. I'm happy that we've done a thorough exploration of this axilla. We found one sentinel node which was both blue and hot. We sent off that as well as a second non-sentinel node, and we will await the pathology on that. In summary then, this patient is a 71-year-old woman with a 2-centimeter primary breast cancer. She had this widely excised at another hospital. We did preoperative lymphoscintigraphy as well as intraoperative lymph node mapping using both the vital blue dye and technetium, yielding one positive axillary node fairly posterior in the axilla, which was both blue and hot and had at least 2 lymphatic channels running into it. I'm comfortable that that is the sentinel node and that there are no other sentinel nodes in this patient. And as per our preoperative discussion, we are going to terminate the operation at this time.